Good morning, guys. Today I'm going to discuss about the important topic that is anti-leprosy drugs. Okay, so the agenda of discussion will be a brief introduction about leprosy, few historical facts, the pathophysiology involved in leprosy, clinical features and diagnosis for leprosy. And as a pharmacologist, I will talk a little bit about the drugs which is used for it, pharmacokinetics of these drugs, and the recent regimen diagnosed suggested by WHO. Okay, so whenever it comes to leprosy, few figures which come to mind, right? Like Mother Teresa, then Hansen was the founder of the causative bacteria for the disease. But when I was searching, I found that there are few other important factors. So leprosy is very old disease than that. A prince called Baldwin IV was about to crown as a king, initially diagnosed with leprosy. The physician who was working there found that he was not crying even whenever pinched by the fellow children. Okay, then he suggested that time itself there is no treatment for this disease. He will progress and succumb to the disease. In spite of the handicap, he developed as a very good king. He ruled till his 24 of age years of old. Okay, and as I said, in 1873, the Norwegian physician who found the causative factor for leprosy, that is Mycobacterium leprae, which lead to the development of various medications which we are using. The pathophysiology of this leprae, already we have discussed that Mycobacterium leprae is the causative organism for leprosy, which is an obligate intracellular bacterial species, which is very indistinguishable from other mycobacterium. And it resides in humans, armadillos, sphagnum and spread from them also. Okay, and it won't present as the glaring features with disability and contracted limbs. Okay, it may start as a macula, plaque, nodular and indurated lesion. Okay, so there is a wide spectrum of disease. It is slow growing bacteria, so there will be a wide spectrum of disease starting from tubercular leprosy to lepromatous leprosy. Tubercular leprosy is the initial stage where there will be one or several hypopigmented macules or plaques with asymmetrical enlargement of one or several peripheral nerves. Okay, especially the peroneal, ulnar, and posterior nerves. Whereas in the lepromatous leprosy, which is the last stage of the spectrum, where there will be symmetrically distributed skin nodules, raised plaques, diffuse dermal infiltration, and causes this classical leonine feces. You can see all the factors which we discussed are here: loss of eyebrows, okay, indurated nodules. So, any patient will present to you at any of these spectrums, and your treatment depends on the stage in which they present. And as I said, these are very slow growing mycobacteria. So, it will take 2 to 20 years or 40 years to establish the disease, but it can be observed in 5 to 7 years also. So, I want to give this chart in a nutshell the spectrum of leprosy. Here you can see the tubercular leprosy, there's a borderline leprosy and lepromatous leprosy. Tubercular leprosy is the initial stage, where borderline is the transition between tubercular and lepromatous stage, where lepromatous is the end stage where severe infection will be there. The number of lesions, bacilli which present, macrophage differentiation, everything has been in detail given in this chart. You can go through. Few things which I want to highlight is there will be fewer skin lesion tubercular, intermediate lesion in borderline, and severe diffuse lesion present in lepromatous leprosy. When it comes to nerve lesions, one or less than one nerves will be involved in tubercular, few nerves in borderline, and majority of the nerves with pain be present in the later stage. Initially, there won't be any pain, but later there will be severe pain also associated with that. That is the variety of leprosy disease we have. Okay, so how to diagnose? As already said, it is a slow growing bacteria, right? And it cannot be cultured in vitro techniques. Okay, so need a living tissue, need a living organism to prove. And to the rescue, we have the mouse. Okay, in the rat or in the mice food pad, they found that this mycobacterium can be cultured, but it will take minimum 2 weeks. So we do have other techniques such as serology, skin testing, and polymerase chain reaction is the recent one with which we can diagnose within a weeks, within a days. Okay. Yes. What happens if we don't treat the leprosy in time? There will be a variety of neuropathies which starts from insensitivity to severe pain, insensitive to pain, insensitive to touch, insensitive to heat, all will lead to severe infections and further trauma, secondary infections when the patient suffering from leprosy. And as I already said, the end stage, lepromatous leprosy, it involves various nerves, right? When it involves cranial nerves, when it involves face, disfiguration of the face, which leads to this leonine facial lag of thermus, corneal insensitivity, and ulceration also. And at the end, there may be severe abscess of the nose, which leads immediate surgical decompressions. So our idea is to prevent the patient to progress to end complication, right? For that, WHO have guaranteed three magical drugs. These are dapsone, clofazimine, and rifampicin. Whereas other agents also were then tried, such as streptomycin, kanamycin, amikacin, minocycline, clarithromycin, ofloxacin, all are not recommended by any of the leprosy control program nowadays. Nowadays, we have three drugs, that is dapsone, clofazimine, and rifampicin. Okay, as a pharmacologist, let's deep dive into the mechanism action of these drugs. Okay, dapsone, which is the most widely used drug for leprosy, which acts by inhibiting the para-aminobenzoic acid, which is required for synthesis of folic acid. Whenever there is a PABA, it will produce folic acid, it will be transcribed into folic acid. As dapsone blocks this PABA, there won't be any folic acid production, so there won't be energy source for this bacteria, and the growth of the bacteria will be stopped. Okay. When it comes to the pharmacokinetic parameters of dapsone, it is very well absorbed orally, very well distributed in the all parts of the body. So the leprosy bacteria which stays in any part of the body will be inhibited effectively. Okay, it will be metabolized in the liver by the process of acetylation and eliminated in kidneys and bile. As you can see, it is eliminated in kidney, right? So any patients with renal failure require dose adjustment. Dapsone is given at the dose of 100 milligram. Okay, as it is a chronic disease, leprosy is a chronic disease, right? So it will be given for longer duration. So any patients with G6PD deficiency are vulnerable for the adverse drug reactions such as hemolysis, methemoglobinemia, and something called erythema nodosum leprosum. Any patient taking dapsone for longer duration vulnerable to adverse drug reactions such as methemoglobinemia, erythema nodosum leprosum. And luckily, we have treatment for the condition erythema nodosum leprosum. And for that, we use thalidomide. Please remember thalidomide. Okay. Clofazimine. Clofazimine is also a electrostatic drug which is used in the treatment of leprosy. It is also given at the same dose of dapsone, that is 100 milligram daily. But we want to know how it acts, right? So the mechanism of action of clofazimine is by disrupting the bacterial membrane. It will go and bind with the bacterial membrane and destabilize the bacteria, which prevents them from moving further. And the oral pharmacokinetic parameter is similar to that of dapsone, that it is very well orally absorbed, very well distributed, metabolized in the liver by process acetylation and eliminated by the kidneys, right? The only adverse drug reaction which is associated with clofazimine is skin discoloration, ranging from red to purple black and few GI disturbances. Please remember this adverse drug reaction for clofazimine that it can be asked as MCQ in various universities from need aspect in INS. Nowadays, any set exams that calculate, all will have this MCQ. Okay, so the adverse drug reaction of clofazimine will be skin discoloration. Okay, yes, and we like to discuss a last drug which is used in the leprosy. And I want to highlight that this is the only bactericidal drug which is present. Okay, guys, so it will prevent the bacteria from producing its own RNA. Okay, so rifampin will block the DNA-dependent RNA polymerase. By that, it will stop the RNA synthesis in the mycobacterium and leading to bacterial cell death. Okay, oral pharmacokinetic is similar to that of all other drugs. Very well orally tolerated, well distributed, and metabolized by the process of acetylation, eliminated by renal kidney. And I want to note you that the dose, the rifampin is given at 600 milligram daily. Okay, and the adverse drug reaction is hepatotoxicity, which is self-limiting. So, if any patient after initiating rifampin complaining of raised liver enzymes, try to reassure them there is nothing to worry. It will be self-limiting hepatotoxicity. Okay, so WHO have given guidelines. Okay, regimens. So right now we have discussed about the drugs. So we know the types of leprosy also, right? WHO have classified the leprosy as possibacillin and multibacillin. Possibly is nothing but lesser infection. That's initial time of infection. Leprosy, which is not progressed to lepromatous leprosy. Okay. At the time, multibacillary means severe infection, multiple nerve involvement. Leprosy progress to lepromatous stage. Okay. So for this, we have treatment. We have already discussed the drugs, their dose also. The only thing is for any patient who has been diagnosed as possibacillary should give the treatment for 6 months, and any patient with multibacillary should receive the treatment for 12 months. Okay, the rest the combination of therapy is same. And I want to highlight here there is a combination of therapy, right? None of the drugs are given alone. Even the patient possibacillary or multibacillary give the treatment the combination of vectostatic and vectoricidal drugs, right? Vectoricidal drug will kill the drug, vectostatic drug will prevent the growth of the drugs. So all these drugs should be given the combination. The only thing is possibacillary given for 6 months, multi-basic given for 12 months. Okay. To summarize, leprosy is caused by the bacteria called Mycobacterium leprae, which is a slow-growing bacteria. It is present in human Thermometer background as a host from which it will spread across. WHO have classified them as possibacillary and multibacillary. Possibacillary is the lesser infective stage, whereas multibacillary is severe infective stage. Okay, and as I said, it's a slow growing disease. It cannot be cultured in vitro, so we need mice to grow. The food bed of mice it will grow effectively, whereas nowadays we have recent advances which will produce results within days. And the WHO have given us the drugs for treatment of it, such as dapsone, clofazimine, and rifampicin. So, any doubts, kindly mention in the comments. And thank you for your patient listening. And if you want to discuss on any particular topics, please post in the comment. And I will be initiating a series of classes. For each week, I will upload a video which has starting from general pharmacology to miscellaneous topics in medical pharmacology. Thank you, guys. And thank you for your patient listening. Stay tuned.